Welcome to another Orthopedia webinar. My name is Chris Adams, and on behalf of the Arthrex Global Medical Education team, we'd like to thank you for taking time away from your families to join us. We'd also like to thank you in advance for your participation in this event. So let's get started.
Great. So good evening, everybody. Welcome to the next edition of our meniscus-focused webinar sessions. Thank you very much for joining us. Wherever you are in Europe, we're pleased that you can take some time to take in this session. So hopefully you can all take a second to grab yourself a cup of tea or coffee, or if it's a little bit later, a glass of wine or a cold, crisp beer. So we'll do our best over the next 45 minutes or so, working with our esteemed faculty to provide you with some excellent educational content. With that in mind, I'd like to introduce you to tonight's faculty. So we'll start on the right-hand side with Dr. Diego Garcia-Germán from Madrid. He's currently working in the University Hospital Madrid Torrelodones, which I'm glad I could pronounce correctly. So there he has a varied practice where he specializes in both orthopedic surgery and traumatology. He is also, in his spare time, I am told, the head surgeon for the Spanish national ski team, which I'll be honest, I didn't know there was one of those. It's as bizarre as the British national ski team as well. But interestingly, he was also a member of that team when he was younger. So it's weird how the world works. We're going to leave Dr. Garcia-Germán on the ski slopes, and we're going to move to the golf course, which is where we will often find our second faculty member, Dr. David Houlihan-Byrne, who we are very fortunate enough to have an excellent working relationship with here in the UK. So Mr. Houlihan-Byrne is an orthopedic surgeon who's based in London, who works in the prestigious Fortius Clinic, where he has a hugely varied caseload, including the management of some complex sports injuries. David's patients often include high-level sports people, including Premiership footballers. So as you can imagine, we are in excellent hands this evening. So let me share with you our agenda for tonight. So we're going to start with Mr. Houlihan-Byrne, who's going to take us through the understanding of the personality of a meniscal tear, which from what I've seen so far stands to be an excellent presentation before we move on to Dr. Garcia-Germán. So with that in mind, Mr. Houlihan-Byrne, thank you very much for joining us. I'm going to hand over control to you, if you don't mind, and I look forward to the next 15 minutes.
Thank you very much, James.
Fine. Excellent. Thank you very much. Right, well, I'm going to save more questions for after we hear from Dr. Garcia-Germán. So with that, if we can pass over control.
So hello, thanks very much, James. Thanks very much, everybody at Arthrex. Thanks very much for the wonderful presentation from Dr. Houlihan-Byrne. And I'm going to go through some of those things he already said. So let's get started, and we're going to talk about different techniques to treat meniscal injuries in the elite athlete. So we know that elite athletes they're different. They have high demands, high physical demands, and they obviously expect a fast recovery, a short rehabilitation period that can get them back to the playing field early. They expect full performance after their injuries, and high expectations, obviously. And we have to take into account what would say third-party interests. Teams, coaches, parents, sponsors, etc., and that's something that we also have to have in mind. There, as I said, this summer, they're not superheroes. They're normal people. They want to heal fast, but one thing is their desires. Another thing is biology, and what the times we need to get them back to the sports. On the other hand, when it comes to meniscus surgery, resecting the meniscus can get them back to the playing field really fast and can make them world champion. But on the other hand, their careers can be shorter, and when they get older, maybe they regret not having had a repair of their meniscus because maybe their careers have not been so long as they should have. And also, we talk about trying to preserve the joint and trying to preserve the function of the meniscus in order to have the best performance possible. We all know what happens when our patients lose their meniscus, and what happens is that they develop early osteoarthritis, and they develop degenerative changes fast, as we'll see, especially the lateral side. But it's also true that preserving the meniscus helps to improve stability of the knee when it comes to ligament surgery, especially with ACL reconstructions. As it has been said before, why don't we repair and suture every single meniscus? Well, because if we suture those meniscus, unfortunately, the rate of resurgery is higher than for resection. So we have to, as it has been said, think about the personality of the tear and the patient and try to select those tears and those patients that are going to do well with repair. We're going to talk about buccal tears of the lateral meniscus, but because as it has already been said, I think it's extremely important to preserve the meniscus in the lateral side. And we know that there's early degenerative changes in cases where we resect this buccal tears of the lateral meniscus. In the medial side, it's already been said, results are not that good. So I think probably the threshold can be a bit lower for resection when we have, as the tear that has been shown before, a not very good quality complex tear, radial tears associated, and more degenerative pattern of tear. But when it comes to the lateral meniscus, this is what happens usually on young patients where the meniscus has been resected, and that is that they develop very early degenerative changes on the lateral side, and sometimes we don't have too much to offer them once we get to the situation where the cartilage is really torn off and there is really an osteoarthritis already settled on the knee. So this is the kind of patients we can see. Young patients, maybe they're really elite athletes because they're having a good career and their progression is expected to be good, and they have this kind of tears. And this is the tears that we have to be really aggressive in terms of repairing them and trying to keep the meniscus in place, because as it has already been said, around 20% failure rate is what's been described for medial meniscus, but there are also various series talking about 0%, that's 100% success when repairing the lateral meniscus with a buccal tunnel tear. So we have to go for a repair in this cases. This is a small video. It is a very similar tear to the one shown before with a buccal tunnel tear of lateral meniscus with this small radial tear associated. So ACL is intact, so it's just an isolated tear of the lateral meniscus, isolated buccal tunnel tear. We reduce the tear to its place with a figure 4 maneuver. And in this case, we decided to resect the small radial tear in order to avoid progression of that tear all the way to the peripheral wall. So in this case, we had less of a peripheral rim remnant there, but as you can see, we have very good vascularity. So we go to try to enhance that vascularity and that biology with trephination and rasping. Also, we use a blade to insert our fiber stitch. It's already been shown. It is an all inside, all suture device. And I think, as has been said, that it is nice not to leave those PICC implants there, but only to have sutures. But it's also fine because, well, in this case, as you can see, we're trying to fix that meniscus to the popliteus tendon, just to have a very good purchase tissue there and have a nice reduction of the tear. And we put the second implant in, as you can see, and then we have to pull from the loop, and we do some counter pressure with our probe, and then we pull from the free end of the suture. And as you can see, the suture is, I would say, less rigid than other devices. And another good thing that this device specifically has is that the suture pretty much converts itself to a sort of tape because it's more flat. So the possibilities of tearing the tissue as we pull from the knot and we slide the knot down, I think it's really lower compared to other devices with a more rigid and more thin suture. So as you can see in this case, it was not a very big buccal tunnel tear, and we can really repair it with just 4 implants going all around the meniscus there, as you see in the images. And this is the final, the posterior most implant. And there you go, just a few more minutes of surgery, and we keep that meniscus in place. And I think that is something we really have to stress about, having this lateral meniscus tears sutures. We can see from the trans-notch view the image of the tear, similar to a ramp tear on the medial side. And on the right image, we see how this tear, this sort of ramp image has been properly closed. Similar to what my previous speaker said before, we have to have in mind what we are going to use in every single scenario and every single type of tear that we're dealing with. And we have to have our implants and our instruments in the room in order to address every single kind of tear with different techniques in use. If the tear goes further anterior, buccal tears that go further anterior, then we can use outside in sutures. And I think outside in is a nice technique, because we can really get a lot of sutures in place with a minimal added cost to the overall procedure. For more complex tears of the lateral meniscus, especially in the younger patient, in the younger athlete, and I think we still have to try to keep that tissue in place, although those more parabeak flap tears are more difficult to reduce and to fix in place. We use this zone-specific inside-out devices by Arthrex with this long needles. And it's true that we need a counter safety incision on the posterior lateral side, but it's also true that we can really put a lot of sutures in place with a very thin needle that's going to really harm very little the meniscus, and we can really get a very nice reduction and fixation of that tear and keep the meniscus in place. When we talk about buccal tears of the lateral meniscus, we have to talk about hypermobile meniscus, because the symptoms of the patients are the same, although most of the time the MRI images are normal. So it's extremely important to correctly address the popliteal hiatus with a trans-notch view, and from the lateral gutter as well, as you see in the right inferior image, and just make sure that the hiatus is in place and that the meniscus is not unstable, because sometimes we can find those kind of tears, obviously. Meniscal root, it's true that most of the meniscal roots, medial meniscus roots, we're going to see occur in the more elderly patient. They're degenerative tears, but we're seeing them with more frequent in more active young patients, and especially we've seen a few cases associated with PCL reconstruction, where the tibial tunnel is slightly anterior and might have affected the posterior root of the medial meniscus, and we've also seen this a few times this year. And also sometimes we see some subtle images in the MRI, which are not very clear, as you can see in the images. We see this absence of a proper continuity with the root, but I would say those are not the most obvious images in the MRI. But then we will go inside the knee, and there's a complete root tear of the medial meniscus that needs repair. So this is another small video on posterior medial meniscus root repair, transosseous reinsertion. Sometimes, as you can see, there's some scar tissue there, and we were using this transtibial technique just with sutures, tying them over a button, as you see in the images. And sometimes we found that we would go back in for a final check. We've lost some tension on the tear, and there was some displacement on the root. So we were using a swivel lock device to fix those sutures to the anterior cartilage of the tibia. And it has been tested that using these devices as opposed to tying the sutures over a button is more reliable. And again, as it has already been said before, the problem with tear of that tissue, we are trying to solve it using a fiber tape instead of number 0 sutures. it's not clear that using a tape opposed to a suture is better, but we really think that the possibilities of tearing the tissue using a tape are lower, and we're using this technique. We've been using it for a couple of years now, 3-4 years now, something like that. So we have this scar tissue there in this medial root tear, and what we do pretty much in every case is that we do a release, a pie crusting of the medial collateral ligament, and I think that is absolutely a must in these cases where you need space to work on the medial compartment in trying to avoid injury to the cartilage. We use a cannula. It can be a passport or a rigid cannula, and we use a meniscal Scorpio. So we exchange the sutures for a fiber tape, as you can see in these images. And it's true that it's a bit more, I would say, complex surgery, because we do around 6 to 8 passes of the meniscal Scorpio, and we pass that fiber tape 6 to 8 times around the posterior meniscal root, and it's, as you can see, more complex. But the truth is that we get a very good purchase of tissue, and we really have, I would say, a low risk of tearing of the tissue, because as you can see, we really have a very nice purchase of that tissue with several passes with a fiber tape. We then do our transtibial tunnel, and we do them from the contralateral side. We use this is the standard guide, but we know there's a new one that is I would say easier to use. So we use a flip cutter, a number 5 flip cutter, to do a small socket in the anatomical position of the tear, fiber stick to pass our fiber tape down to the tibial side. And as you can see, we get a very nice reduction and a solid fixation using a swivel lock on the tibial. We try to leave this swivel lock slightly proud so that we have a very good fixation on the cortex of the tibia. And we really recommend going back in, because with the swivel lock, you can, as opposed to tying those sutures over a button, you can go back and try to have a proper tensioning of the sutures. So meniscectomy, I think this is also important, because unfortunately, some of the meniscal tears we're going to treat in these patients, in the athletes, they're not going to be amenable to repair, and we're going to have, unfortunately, to do a resection, such as in these cases where we know that probably our suture is not going to work very well for these cases. So it's super important that if we're going to do meniscectomies, and we're going to do them, is that we do them well, and we try to avoid probably the most frequent complication, and it's been coined as the Atrogenesis Imperfecta recently, and that is the damage to the articular cartilage while using our instruments inside the knee. So as it has already been said, first, do no harm. We have to protect the cartilage. It's when we do a meniscectomy, we know the rehabilitation period is very fast. So we have to do a surgery, a very keen surgery, and we have to try not to do any injury to the cartilage. And as I already said before, with meniscal root tears, release of the medial collateral ligament is super important, to try to improve just a bit, just a couple of millimeters, enough so that we can work in the posterior medial compartment safely with no injury to the cartilage. And this is not only going to help us work in that compartment with less risk of chondral damage, but also in terms of diagnosis of the tears, and to really see the personality of the tear, as has been said. Also, super important not to hinge, not to press on the medial femoral condyle on the cartilage. So sometimes we have to lower our portals just to make sure that we can access properly the most posterior part of the meniscus. And also a very interesting thing that sometimes fellow surgeons are not so and it's not so evident, is that sometimes when we try to open the medial compartment, we are reproducing a fixed pivot shift in cases where the ACL is already torn. So sometimes we need a slight external rotation to reduce that pivot shift and get a proper access to the posterior medial compartment. So thanks very much. And again, thanks to Arthrex, and thanks to everybody joining tonight, and hope you enjoyed it.
Excellent. Thank you very much. First of all, gents, really appreciate the time you put into those talks. I think there was fantastic balance to that session. Mr. Julian gave us a great guide into his thought process when he's deciding what to do, and some background. And Dr. García-Germán, that was excellent technical demonstration of how to manage certain repairs. So first of all, from an Arthrex point of view, you know, we're thrilled that we can play a part in helping you guys manage these patients. To see Arthrex products form a part of your care pathway for any patient, regardless, you know, is fantastic for us, and that's the whole aim of everything that we do. I have a question to kick off, if you don't mind, and it's something that I'm quite fascinated about, and I almost feel for you guys in many senses with this issue. But Dr. Garcia-Germán, you mentioned at the beginning as well, that kind of quandary around the decision you make with your athletes, particularly, you know, when it comes to meniscus, do you repair the meniscus and potentially keep the athlete out of action for a little bit longer? Or, you know, as I imagine most of them are hell bent on getting back as quickly as possible, do you consider a meniscectomy? And I imagine there's different times in their career when conversations vary. So, you know, but how do you both, and actually we'll go back to Mr. Julian, how do you manage that conversation with your athlete and the thought of getting them back early, but potentially shortening their career versus longer out and repairing and trying to preserve the length of their participation?
I think it's really difficult. And, you know, one of the first questions you'll ask a player, well, often you're communicating directly with the physio, is what's the contract? You know, how much is left on their contract? You know, what's going on next season? But I really try hard not to change my standard principles, which is, you know, save the lateral meniscus at all costs and be a little bit more relaxed about the medial meniscus. And I think if you sit down and you have a sensible conversation with these players, the younger, the more important it is, because they've got a longer playing career. And I think, you know, the problem is it is 3 to 6 months out for these guys after a meniscal repair. And, you know, it's not an ACL reconstruction. They don't have a lot to show for it. So they you know, it's a bit miserable for them. Slightly different coming towards the end of someone's career. But again, I won't ever be swayed about taking out a whole lateral meniscus if I find a bucket handle lateral meniscal tear. But a lot of these players, actually, they present with small radial tears that aren't necessarily repairable unless you've got one on the lateral side, which you think you can stitch back together. But it is difficult, and I think you've got to stand by your principles as a surgeon who treats elite sportsmen.
Yeah, I agree. Dr. Garcia-Germán?
I totally agree. I think it's also a very important thing to know that for some of these athletes, those few last years of professional activity maybe are going to be their main economic income for the rest of their life. And that happens in terms of economic independency for the patient, for the athlete. So maybe they think about a fast career and very successful career, but maybe in terms of their economy, those 3-4 years they've been playing in China or Qatar, wherever, they really make a big difference in the long run. So I think that has to be stressed, because it's not only their short, successful career, but sometimes, and some of our athletes end up being instructors or being coaches, and they really need to be active still. So I think it's very important to stress those things, that it's not just their career, but on the long run, they need to stay active also.
So with that in mind, Dr. Garcia, we'll stay with you. From a technical point of view, or from a demand point of view, post-surgery, your athletes are going to be expecting an awful lot more of their knee than perhaps Joe Public. Technically, would you do anything different with an athlete versus a member of the public when it comes to their meniscal repair?
I try not to, as has already been said. So I think we should all stick. It's true that sometimes we can be more aggressive in terms of suturing those tears, especially the lateral side. And you also know that the patient is going to give 100% with the rehabilitation process, and and they're really going to try their best to get back to the sporting career. Whereas maybe the general public, the general patients, sorry, it's going to be harder for them to go over a painful rehabilitation process. But I try to do the same thing with my patients. I try to think about the tear itself and the kind of patient, but I try not to do different things.
Right. And then back to you, Mr. Hulan-Byrne. Obviously, we're seeing elite performance athletes. The demands on them, the physical demands on them, are changing every year as professionalism evolves. Are you seeing any difference in the injury profiles, or maybe the frequency of injury that these players or patients are coming to you with? Has it changed over the last few years? Have you noticed any difference?
I think we went through a phase when footwear changed and playing surfaces changed, and players were playing in blades on 3G surfaces, and I think we had a lot of problems with those surfaces, with ligament injuries as well as with cartilage injuries. But the technology, the biological technology in terms of prehab, pre-season training, the physio care of patients, particularly in the higher clubs in the Premiership, is second to none, and they are looked after well. And the Alter-G running machines, the technology has moved on in a huge way. So I think these players are huge commodities. They are worth a lot of money to these clubs, and they are looked after, and the monitoring and the recovery from injuries is much better than it used to be.
Excellent. Cool. Well, I've asked my questions for now. Do either of you have any questions for each other before we move on?
Well, I was going to ask, the one thing we can't decide on in the UK, and I'll be interested to hear from Dr. García-Germán, is rehab. And we all have different rehab protocols after meniscal repair. I have my own. It's not the same as some of my colleagues. And I just wondered what you did, and whether you did something differently, whether it was a medial repair versus a lateral repair, and how long you'd let them go back to sports such as soccer or skiing, and whether it differs.
I would say generally I am quite conservative. I let them do full weight bearing from the start when it is a vertical longitudinal tear or bacchanal tear, not when it is a radial tear, a more complex tear, or a root tear. Those patients go 6 weeks non-weight bearing. Not really in terms of medial or lateral. When it comes to the medial side, I'm very cautious with full flexion, especially weight bearing full flexion. And I tend to slow them down as much as possible, especially in our sports, winter sports, depending on the time of the season. So we can wait till the preseason in September, and we can get a couple more months out of heavy training. I try to wait as much as possible regarding the calendar, but it's around the 4 or 5 month timeline to go back to skiing in my case.
I think it's a really important point for people to take away. In fact, there's two important points I've taken away from your talk that the listeners should take away. One is the ability to open up that medial compartment with the pie crusting. It's a really underused technique, and there's nothing more miserable than seeing a femoral condyle damaged while someone's been struggling away with a medial meniscal repair. And the other interesting one is in the ACL deficient knee, how difficult it can be to open up that compartment with the rotation, and to get an assistant to hold that foot in external rotation is a really good tip.
Yes.
The other question that came up in a recent webinar that I did was how we assess for healing. And do you use any in-office arthroscopic techniques like nanoscopes or things like that to look inside the knee at any time?
We haven't used it yet. I'm really willing to use it. I don't know if you have already, but
no, I have in theatre to try it out, and I was very surprised about the view that you get, and I'm just looking for the indications to use it really. And for me, diagnostically, I think MRI is very good, and our good scanners now are going to tell us as much as we need to know. For me, it's really for the patient that's struggling 6 to 9 months after a meniscal repair, particularly the complex repairs, to have a look inside and just see what's going on in terms of whether it's healed or not, because often those MRI scans are difficult to interpret.
Yes, they are. I think in my practice, I really guide myself by the symptoms of the patient. So if the patient is not doing well and he has pain, for me, most of the times, if I go back in, the meniscus is torn and they have a re-rupture. Yeah. So if everything's going fine, I don't usually do control MRI scans all the time just to check, because we know that there's also the scar tissue that can have an hypersignal in T2, and they can confuse the radiologists with a new tear or a re-tear. So if everything's clinically going well and the patient is doing well, I do not get routinely MRI control. If it's not doing that well, you're going to get an MRI definitely. But if it's not doing well, most probably I'll go back for a second look. And my experience is that most of the time the meniscus is torn again.
That's right. I think that's right.
Yeah.
Excellent. Thanks, guys. I want to, I'm conscious of time, but I've got one more question that I'd like to pose to both of you. We thoroughly enjoyed learning from both of you this evening, but I've got last question for any surgeons who are about to embark on the management of professional or high-level athletes. What advice would you have to someone who's about to take on that role?
Don't do it alone. Be in a team. And that team involves colleagues, like-minded colleagues, physical therapists that you know well, and I'm afraid if you're going to take on elite sportsmen, you have to be prepared to have your phone available a lot of the time for the club physios, because their demands on your time are not insignificant. So put some time aside.
Dr. Gaman?
I would say for me, one of the most complex things is dealing with everything that's around the athlete, and that is coaches. But for me, I also see quite a lot of young athletes, and parents are really pushy in terms of going back after an injury, and sometimes it's hard to deal with all this, and you really have to make them know that you're doing the best for the patient, the best for the athlete, and thinking about their career, not only the really short-term goals. So I think that's really important.
Perfect. Thank you very much. Gentlemen, I'd like to thank you so much for your time and your efforts in preparing your presentations and delivering them this evening. I have thoroughly enjoyed this session. I think it's been excellent, and I'm sure I speak for everyone at home who's taken the time to view this as well. Thoroughly enjoyed it. My parting comments, I just want to bring up the fact that for our UK delegates as well, we have managed to get these sessions accredited by the Royal College of Surgeons. So if you'd like to claim your CPD points, please email cpd@arthrex.co.uk. And for anyone who's watching out there who'd like a little bit more information about anything they've seen this evening, I'd encourage you to reach out to your local Arthrex contact, and I'm sure they'll be able to help you. But if they're not, we are an incredibly well-connected team within Europe. We will have someone who can help you get to the bottom of your problem or your question. So with that, gentlemen, thank you again. Everyone at home, thank you for joining us, and we look forward to seeing you all very soon.
Thanks very much, James, and thank you, Arthrex.
Thank you too.
Thank you once again for joining us for this event. For more information on any of the products or techniques, please contact your local Arthrex representative. You may have also noticed that these webinars are hosted on our new Orthopedia site. Orthopedia is an online educational platform of orthopedic videos for you and all your staff. Please spend as much time as you want navigating through the website. It is open 24 hours a day, 7 days a week, with no login credentials required. We hope you enjoyed, and as always, we look forward to your feedback about how we can help you treat your patients better.